But at the very top of the list, we know this. It's very important to have a champion at your site to from the get-go to get things off on the right foot and to make sure that up the ladder, down the ladder, and both sideways across the ladder that that you are supported because it takes a lot of support. You all know that from your supervisors, management, and administration because you got to have the resources to do this. As mighty as each of our champions is, they can't do the whole model by themselves. It does take a lot of support to get you the resources that you need, including that important backup we talked about. Is there anything you all would like to add about the importance of having a strong champion? All righty then, enough said about that. And then it's very important for a site to have the vision, and to have a long-term vision, not just to sign the letter of agreement, but what does that letter of agreement really mean? Because part of that is looking forward and figuring out ways to sustain the program over time, even beyond Compass resources. And in order to do that, of course, they need to understand the financial benefits, maybe not all the time in hard dollars we can see, but you certainly can see some of that, especially for sites that we're not already doing TCM billing, CCM billing, extended visit billing. We hope we've taught you all a lot about that, and you're all doing it now. Not to mention when you first become an intervention site, just like you guys, you get that additional, in addition to the $50 you get for enrolling the patient, you get the $105 for getting the patient back to the clinic visit and the care plan. But way beyond that, and some of our sites, particularly Wave 1 sites, are already seeing this, you're telling us about it, you start seeing your readmission rates going down. And Sarah spoke about this at boot camp of Hugh Chatham's being down to between 2 and 3% now, and that's almost unheard of. That's just right next to being perfect. And it was already good. Their readmission rate was already good, but over the course of the past year, it's come down, and it's great. So we have to look at soft dollars as well. And as you move into sustainability, and I know these sites are doing that, you have to justify to your management and administration that Compass is not only benefiting patients and they're happier about it, that it's benefiting the hospital too, and the community, and the bottom line of hospitals and practices. Is there anything, because you guys are doing a great job of this already, is there anything else to add to that? Sarah, anything else you want to add? I know that Pam and Misha are coming to make a visit to you guys. I think it's next Wednesday to talk to you more about how you have convinced your management and administration and how you're looking at all of this as we look at, not only the patient outcomes, but the value-based outcomes for hospitals and systems. Anything else you could add?
The only thing that I would add, just something that I do since the very beginning, we knew that we were going to have to prove this program and show that it is sustainable, because we were afraid as soon as, you guys quit reimbursing us that they would do away with it. So from the start, I keep a spreadsheet of every patient that I enroll. When they meet, or when we do the 2-day call, if they come to the 7 to 14-day visit, the TCM code that we bill them for. So if we use transitional care codes, we document that so that it shows. And then, of course, we've got our readmission rates and everything like that to show also. But that kind of shows like what we've brought to the clinic, and things like that.
That's awesome. Sarah, I can't remember if I've asked you this before, but is that something, certainly we're not asking for all of your information in there, but is that a template that you could share with me?
Sure. Yeah.
That would be awesome if you could just send that to me. I would appreciate it. You're probably going to get asked by Pam to look at it next week too, just as a little heads up.
I mean, it's very basic. It's just patient name, account number, and then each of the goals that were met. 2-day call, 7 to 14-day visit, 30-day call, 60-day call, and then at the other end, it's got the TCM codes that we bill for.
Yeah, and just and you don't have to answer on this call, but you can, when you send that to me, when you email that to me, if you would let me know if at some point you're okay with us sharing that with some of our intervention sites that are trying to prove the same thing. But I know you say it's simple, but sometimes the simplest of tools are the most effective. And if you guys would be willing for us to share that, it's just kind of like Jane Anderson was saying from a therapy standpoint and getting sites trained for their home health and outpatient team leaders to get trained. They have a checklist that they use at Mission and with care partners, and she said she brought it to boot camp to share. And when she showed it to me, and I had seen it before, she said, this is very simple and people might not want it. And if they don't, they can give it back to me and I'll recycle it. And I was like, trust me, they're going to want it. And of course, because, something that's a very simple tool that's working for one site, other sites can tweak it and make it work for them too. Because sometimes getting that first simple tool is the hard part.
When I said simple, I kind of meant more that it's just a basic Excel spreadsheet with those labelings on there. I don't really have a template for it. It was more just for my knowledge and to show when it did come up for review as far as budget and things like that.
I think it sounds perfect, and thanks for sending it to me. And then we have organizational buy-in, which really kind of relates to champion and vision. As I mentioned before, it's just really important that COMPASS is accepted as standard of care. We've been talking more about that and presenting it to the patient that way, that this is our standard of care for all TIA and stroke patients going home from a particular intervention hospital, and that it's treated that way, just like any other standard of care, that you have the resources in place to implement it, that you have backup, and so on and so forth. Anything you guys want to say about organizational buy-in and how you've been able to do that at your particular site? I know at least one of you just sort of went before your leadership and said, this is what we need to do. And because they trust you, it was basically, okay, what do we need to do to make this happen kind of thing. It's not always that straightforward, and we know that sites have to get creative. Their champions have to get creative with how to get that organizational buy-in and make it a true standard of care. And then if we move on down to coordination with direct care staff, one of the things that we have learned, and we did that here even at the Vanguard site after we were up and running. Christina will remember this. We were up and running for a while, and we got to thinking, we told our case managers and discharge planners about COMPASS, but it seems like, there's so many of them in a large major medical center like this. Seems like maybe some of them don't know what we're talking about, or maybe we could get some additional help with patients before they're discharged if we made sure that all of our staff, not just the COMPASS PAC and APP, understand the model, but if we bring in other direct care staff and make sure that they know, then they can help be our eyes and our ears, because we can't, PAC and the APP can't always be at the hospital 24/7, enrolling all the patients and knowing when the patients are coming and going, because they come and go so quickly. So we have learned that that's really valuable, is to figure out ways to make sure that your line staff are educated about COMPAS, and up to and including that discharge planners can oftentimes make sure that, for instance, like the 7 to 14-day visit gets incorporated into discharge orders and actually gets printed out for the patient, and they see it right there that that's just as important or more so than anything else that they're being asked to do post-discharge. Anything else you want to say about how you coordinate with your direct care staff?
I think that's great. This is Christina. And we also did some grand rounds and kind of connected with the main care coordinators. But it's so true. People change jobs so quickly, and there's always this in and out. So trying to kind of consistently keep COMPAS kind of throughout the hospital on updating maybe do every year, kind of try to do grand rounds or more educational opportunities is probably really important, because it is hard. People switch around a lot.
That is so true. That is so true. And we learned that right here at our own site, that we needed, we certainly needed to do an update a few months after launching here. So that's,
and it gets more, and it gets tougher with the teaching hospitals, because you're definitely switching roles.
That's right. That's right. Very true. And then if we move on down to number 5, consistency with staff. Sometimes we just, things happen. People move, people take new jobs, people get promoted, people have babies, people decide they want to go part-time, all kinds of things happen. But the more consistent that we can be in keeping the same PAC and the same APP, because they get their systems. You know how it is. You guys know you got your systems in place. Dawn, you with Dr. Galat, and Sarah, you with Bill, and Deb, you with Terry. You guys have your systems down, and you want to train your backups to have those same systems so that you're consistent in what you do, and people know who to go to if they have questions about COMPAS or whether a patient's appropriate or not, and all of that. But it just makes things more efficient and effective. You guys can probably, your PAC and APP teams could now probably see a patient with your eyes closed. Just because the left hand knows exactly what the right hand's going to do and say. And that's just invaluable for all reasons. Anything else about consistency? You guys have been very fortunate, all 3 of your sites that are on today, that you've been able to be consistent, and Christina with the Vanguard site too, to have Gail all along the way. Because you just think about, if one of you left, what that would do to your counterpart, and particularly if you don't have great backup. But even if you have backup, Emily's great backup for you, and you have great backup in James, Dawn. But if one of you were to leave, I dare say Emily or James would be going, what are we gonna do? So consistency is really, really important. And then that just moves into backups, making sure that you have appropriate backup. We can't say that enough, and we know some of our current intervention sites are still struggling this far into intervention to get good backups that they can really count on. When Rika and I meet with these sites on a monthly basis, I feel their pain sometimes. I've had PACs tell me, for example, I just don't feel like I'm going to be able to take another vacation until next June, because that's when, we're going to have our new budget and maybe I'll have some backup then. And I'm like, what? That's a heavy burden. So backups, backup. Patient recruitment and identifying eligible patients. And one of the things there, that we mentioned already before, is if you talk with your other staff and your line staff, whether it's the ED or your case managers, discharge planners, whoever you identify in your hospital are people who can really help you keep your eyes and ears to the ground of what's happening with these patients. Make sure that you are, you know, and I know you've already got your systems in place, so I'm sort of preaching to the choir here, but it really helps to pick up missed patients when they're in and out so quickly, especially these TIA patients and OBS patients. They may be in and out before you ever knew they came and went. And if that's the case, at least to get alerted by beep or buzz or email, whatever, as quickly as possible so that you can follow up with them with that phone call and then send them the packet. Is there anything that you guys are doing that you feel like is creative that wasn't shared at boot camp or that we could share with Deb? Okay, quiet again. Is there anyone who's using a banner? When we talked about use of a banner at boot camp the last couple of days, a lot of people didn't know what we meant by banners. But what we mean is, you know, those flags, those banners, those different colors that sometimes are on the medical record. Sometimes there's a banner for allergies, for example, or if they're diabetic, so on and so forth. So for systems that have banners, we just encourage, you know, to put a different color banner that says COMPASS. So everyone who sees that record knows that this is a COMPASS patient. Have any of you guys used a banner? Have y'all used a banner? Sounds like none of the sites that are on have, but
Yeah.
we know some of our sites have.
We haven't actually done a banner at the Vanguard site because we had so many people with banners already, transition teams, and there were so many. But what we started doing was putting it, more recently, there's a lot of referrals. So we've placed in the referral forms when they come in through the residents or anybody makes appointments. So it says COMPASS patient on the referral. And so that's been helpful. Hopefully one day we'll get a banner. I think we put a request in to Epic, and probably a year ago we did that. So we're probably still waiting.
Yeah.
Yeah.
Might be a good reminder to follow up with whoever you put it into and say, oh, it's been a year now. We're going into sustainability. Do you think we could get that banner?
Exactly. We're low on the toll. Like, we're really low down there. They won't.
Never too late. Never say never. Never too late. And we've talked about discharge order a little bit higher up. You know, if you are working with your discharge planners and case managers, to try to get the 7 to 14 day visit put on the discharge order, just like any other follow-up doctor's office visits or outpatient therapy or whatever else is on their discharge orders. Are you guys doing that? Anybody doing that? Well, maybe that's something that could be considered, because for sites that are doing it, they say that this is really helpful. And speaking of the 7 to 14 day visit, one thing that we have learned is that if the clinic is in some sort of specialty area, we see higher rates of patients come back than if they go to, for example, a primary care practice that's, whether it's their own primary care practice or another primary care practice. It's just harder to understand patients when they have to prioritize all of these many appointments that they have to follow up on. It's difficult for them. So we know at the top of the list, if they come back to a neurology office or practice or outpatient neurology at the hospital, that's the most effective. And second to that would be a cardiology clinic. And thirdly, if neither of those are available, and that's sometimes the case in our smaller communities or more rural communities, then to try to get patients to come back to some sort of outpatient clinic at the hospital. And we're piloting at a couple of our hospitals now, coming back to hospitalist programs. And we believe that when we've lost APPs and PCP offices, we're encouraging the hospitals to, when they get their new APP, to have that be someone in the hospital, whether it's a hospitalist program or some other hospital-based program, because patients just understand that better. It's hard for them to understand why they're going to go to one PCP office before they go to another. So that's something we've learned, and as we're working with these new sites to set their follow-up clinics, clinic locations up, we're encouraging them to use one of those options. We all know how important it is to communicate that clear purpose of the 7 to 14-day visit, and starting before the patient ever leaves the hospital, reiterating on the 2-day call. And one of the things that we talked about at boot camp, we talked about it a little bit on our implementation committee call this morning, is another thing. It'll take a little bit more time, but it might really help to get the patients to understand the criticality of that visit and getting them back. And that is to take like a sample care plan, just to print off one of the e-care plans, a sample, and not to overwhelm the patient, but to say, you know, yours will be individualized like this, and we can help plug you in on this care plan to resources. This is a very different visit than any other visit you're going to go to. It is that transitional care visit to help you get connected with all of the resources that you need to find your way forward. And the other thing that Skip came up with this morning, and we know that that some of the sites, intervention sites, have certainly gotten creative with how they've been able to purchase some blood pressure cuffs to share with patients who can afford them. Skip even brought up the fact that in addition to the dummy care plan, that if we could tell patients that if they need help keeping their blood pressure monitored is so important, that when they come back to that visit, if they can't get a blood pressure cuff, that they're a site who feels like they may be able to help the patient could say, you know, we'll give you a blood pressure cuff at that visit and teach you how to use it as well, which I thought was a really great suggestion. Other things that you think we should make sure we talk about as far as the 7 to 14-day visit and getting patients back? I think those are some really great suggestions, and just another reinforcement for seeing the patient before they actually leave the hospital. Some hospitals still have monthly medical provider meetings once a month, like they have a dinner meeting. I know a couple of our sites that are crossing over from control to intervention in Wave A do have such. And we're just saying to make sure that you try to get on the agenda, even if it's only 10 or 15 minutes, to tell them something high level about COMPASS. And this is to support your patients as they come back to you, you know, make sure they understand there is no competition. You know, you can get any issues that may need to be addressed out in the air. If there are reimbursement issues, like they don't want to be competed with for the TCM billing, well, then you know that up front, and any other issues that maybe you can address ahead of time. Anything else to say about that suggestion? Well, the next 4, 13, 14, 15, and 16, are engaging critical partners that we have learned that are very, very strong supporters of the COMPASS model. Many of them across the state have been trained and are just critical to have on your community resource network from the get-go, and to help you to message about COMPASS not only within their particular disciplines, but also because these are folks and disciplines who tend to know a lot of different people in the community, and that's pharmacy. You know, we talk a lot about Community Care of North Carolina pharmacies across the state that do those specialty kind of expanded pharmacy services. The AAAs, the Area Agencies on Aging, that's kind of one-stop shopping in many of our regions. You can just go to them, and they have a lot of other resources under their umbrella that they can refer the patients and the caregivers to. Social workers within hospitals and within systems, they're already making lots and lots of referrals, and they already know about a lot of these resources. So if you don't already know a good social worker at the hospital, it's important for you to get to know one, because they can help you from the beginning, filling out the Community Resource Network grid and helping you all along the way to connect patients. And paramedics, particularly if there are paramedicine programs in a community. Is there anything else you all want to say about engaging partners? We talked about that a lot at boot camp over the past 2 days, and how critical that is. It's not necessary for the PAC or the APP to know everything about all of the resources in the community. It's just important to know those key people who do know about all of those resources and how to get in touch with them and use the community resource directory and so on and so forth. Well, that's a good segue into the COMPAS website and making sure that it is used. It is a wealth of information there. There are all sorts of documents and videos and webinars and Movement Matters documents for patients and providers and so on and so forth. But we put a lot of information on there, and it's just really important that we continue to encourage everyone to use the website, and we hope certainly that you will continue to go to it, because when you stop having your aggregate calls, you won't be coming live to webinars like you were in the past, but we will post them, and we'll let you know when we do post new ones, and we hope that you will continue to go to the website and take advantage. That's one of the things we're going to ask you about on the satisfaction survey. Which of those did you find helpful? What else would you like to see us provide ongoing education and training about? And we want to know how valuable you have found those and what else would be helpful. Flexibility and collaboration, I don't need to tell you guys how important that is. Being able to think out of the box, like Dawn did when she kept looking for a nurse to be her backup, and she tried and tried, and finally she just kept coming back to, we have a paramedicine program. They're already very involved in our stroke program. This is who it needs to be, and we negotiated that, and it's been a perfect solution. But just kind of that can-do attitude of doing whatever it takes to get these patients through the model and to sustain COMPAS, and we know that that's exactly what New Wave 1 sites have been doing. We've talked about standard of care and making sure that it's presented to everybody that way, both in hospital teams as well as patients and caregivers. I think that if we all do embrace COMPAS as a new standard of care, then we're going to be more successful at every touch point along the way of the model. And last but not least, making sure that everyone feels comfortable consulting with COMPAS staff. We had Vanguard experience to begin with, and we continue to study the Vanguard site, but also now we have 20 intervention sites that we've been studying for several months, and some for over a year now. So we don't know all the answers, but oftentimes we use that 3-foot rule. Someone will know someone who will know someone who will have the answer, and we start with, our team, and we branch out across our consultants and our partners and our key stakeholders. So anything about those last 4, website, collaboration, standard of care, or just making sure we all use our resources with consultations and phone calls and emails and all of that. And hopefully you all have felt comfortable reaching out to us anytime you have needed to.